The next session is Crisis of Ethics Review and Research Ethics Committees in the COVID-19 Pandemic. It is my pleasure to invite the moderators, Dr. Suneeta Krishnan and Dr. Priya Nanda from the Bill and Melinda Gates Foundation. Dr. Suneeta Krishnan is India Country Lead, Measurement, Learning and Evaluation at the Gates Foundation. Her team is responsible for grant making to inform and evaluate the Foundation's investments in support of India's health and development goals and to enhance the national evaluation ecosystem. Suneeta is a social epidemiologist with 20 years of experience conducting research and engaging policymakers on health and social equity in India. Earlier, she served as country director of Research Triangle Institute's Indian subsidiary and held faculty positions at the University of California, San Francisco and Berkeley, the Indian Institute of Management, Bangalore, the St. John's Research Institute, Bangalore, and the James P. Grant School of Public Health in Dhaka, Bangladesh. Suneeta has an AB in Biological Sciences from Barnard College and a PhD in Epidemiology and Biostatistics.
I think we've lost Sumana.
Yeah, sorry, she should be back again. Sumana?
Yes, am I back?
Yeah, you're back.
Sorry for that. Suneeta has an AB in Biological Sciences from Barnard College and a PhD in Epidemiology and Biostatistics from the University of California, Berkeley. She is a recipient of the 2004 US Presidential Early Career Award for Scientists and Engineers. Dr. Priya Nanda is a Senior Program Officer with the Gates Foundation India, where she leads the measurement and evaluation for social norms and equity. She was at the International Center for Research on Women's Asia office in India from 2006 to 2016, where she led a portfolio of research on measurement and evaluation of women's economic empowerment and reproductive and sexual health. She was the co-director of the ODI-led research consortium on gender and adolescence. Priya holds a PhD in health economics from Johns Hopkins University, an MIA from Columbia University, and an MA in economics from the University of Delhi. Over to Dr. Suneeta Krishnan and Dr. Priya Nanda.
Conference for giving us this opportunity to co-host this dialogue with you. And it's especially sweet for me. I was very actively involved in NVC2, co-hosting that in Bangalore in 2007, 13 years later. It's wonderful to see how the conference and the community involved and interested in bioethics has grown in India. So our dialogue this evening is, I think, going to be a very engaging, provocative, and interesting conversation. I'm going to take a few minutes to provide a little bit of context for everyone on CoreNet, a COVID research network that's been active since April of this year. I will then hand over to Rohan, who will introduce our speakers, and then Priya will take over for the moderated discussion. Next slide, please. Great. So to give you a little bit of context for where and how we came to this conversation today, it started back in April when we established a community of practice called CoreNet, the COVID-19 Research Network, which aims to build a community of practice to foster exchange and collaboration among researchers and research organizations, gathering information on issues relevant to the COVID-19 pandemic in India. Essentially, in April, a handful of organizations came together to take stock of how we would engage in responding to COVID-19 in India, particularly from a social science perspective, and how we would track its impacts on lives and livelihoods. And that sort of gave birth to this network. Next slide, please. we identified 4 key issues that we felt we should be tackling as a network. First and foremost, it was clear that all research that would be conducted in India in the context of this pandemic would need to really be oriented towards use and users, meaning, what is the data going to be used for, and what do users of our data, the decision makers, be it in government or in civil society, what do they need to know? What questions do they have that we should be helping to answer? Second, it was clear that the pandemic was going to have myriad impacts on myriad groups and across geographies in India, and that it would be very important to bring together, to aggregate data and insights in order for us to have a better sense of how this was playing out in the country. And so it'd be very important to actually bring together researchers working in different parts of the country who are looking at different subpopulations and asking different kinds of questions pertinent to different interrelated domains, for example, domains of health, nutrition, livelihoods, etc. Thirdly, we realized very quickly that it's going to be very important to reduce unnecessary duplication and also noise. That, if many of us were conducting research and taking these data to the same set of decision makers and stakeholders, they could very quickly become overwhelmed. And that would be very important for us to really be very strategic about how we were going to engage in data collection, to try and be complementary and to also work in a coherent way. And last but not least, and highly pertinent to the conversation today, is that we quickly realized that we were going to need to focus on issues of ethics and equity. It was very clear, very quickly, that there were some subgroups of our population who were getting affected disproportionately. We also realized within the first weeks even of the pandemic that risks and vulnerabilities were dynamic, that they were changing rapidly over time, and that it would be really important for research to be paying attention to the nature and scope of that vulnerability. And that because of the acute vulnerability that the pandemic both highlighted as well as produced, we would need to pay close attention to the ethics of doing research. And that is really what has brought us here today. The goals of the network are to maximize the impact of research for researchers, but also specifically for the communities that we aim to serve through our research, and to bring ethics and equity front and center into all that we do, in terms of data collection, as well as data analysis and data communication. This timeline, I'm not going to spend too much time here, but just shows you how over the course of the year, the network has really started to mature. We started with a roundtable hosted by the Omidyar Network India in April, and then went on to develop a web presence, a Slack workspace where members can register and then engage very actively with each other and share resources, exchange ideas, etc. And then we've had a whole series of dialogues surrounding domains of research, such as the gendered impacts of COVID, the impacts of COVID on lives and livelihoods. But we've also had a series of dialogues on ethics, research ethics. Next slide, please. The CoreNet community currently has 50 member organizations, over 190 members who are active on the Slack channel, over 75 research projects, and about 140 resources that are all available at the website www.corenet.in. And also at the website, you will find various recordings of the dialogues. Some of the dialogues are members only, which you can access once you register into the network, but many dialogues are open to the public as well. Great. So just to provide some additional detail on the kinds of ethical issues and challenges that the CoreNet community has been exploring, examining in depth and addressing. This slide sort of shows sort of 3 clusters of issues that members have been grappling with. One is just, sort of straight up research ethics in terms of what kinds of ethical standards, minimum ethical standards, should all of our research in this crisis situation be adhering to. And there are very specific ethics concerns associated with these mobile phone surveys that have become nearly ubiquitous. A second set of issues have to deal with the fact that many of our research respondents are in distress. They are under various kinds of stressors. And how do we ensure that the act of collecting data and information, which is really to help them, doesn't inadvertently exacerbate that distress? And the third set of issues has to do with this idea of vulnerability and equity. Who is, for example, being left out through these mobile phone surveys, and how do we ensure that we are gathering information on their needs and their circumstances that need very urgent attention? As I noted, our coffee hour sessions with members have been conducted, and they've focused on issues of informed consent. They've also focused on issues related to IRBs and how they've responded. Next slide, please. And then we've had these public conversations as well around, balancing a timely response and collecting data through these rapid phone surveys, and what are the ethical issues associated with that, the ethics of sexual and reproductive health research conducted in the context of this ongoing pandemic, and then finally today. So I think this brings me to the end of the context setting part, and I am going to now turn it back to Rohan and then over to Priya.
Great. Thanks so much, Suneeta. This is Rohan. I work at Quicksand, and I help facilitate and anchor the CoordNet Secretariat. It's been a great fortune to work with all of the researchers that we work with. I'm really happy to introduce the set of panelists today. First up, we have Dr. Mala Ramanathan, who teaches the Masters in Public Health program at the Achuta Menon Centre for Health Science Studies at the SCT IMST. She's a trained statistician, demographer, and also a medical anthropologist. She was an ethics fellow at the Harvard T.H. Chan School of Public Health in 2002 to 2004. And since then, she's been part of the bioethics movement within the country. She's one of the working editors of the Indian Journal of Medical Ethics, which is a leading bioethics journal published from India. She's also the member secretary of the IEC at the SCT IMST in Trivandrum since May 2014. So without further ado, I'd request Dr. Ramanathan to kindly share her thoughts. Thank you.
Good afternoon. Am I audible?
Yes, you are.
Yes.
Okay, good. And to make life easy, I don't have a PowerPoint presentation which needs to be loaded. What I'm going to be talking about is in the dual role that I have, one as an IEC member and the other as a social scientist who started to do research on the COVID pandemic situation, particularly in Kerala. I want to talk about the unique challenges that came up during the pandemic and the COVID research in terms of the ethical challenges faced by the ethics committees and the researchers, and what kind of advice the IECs gave them, particularly dwelling on informed consent, and what were the unique adaptations that came up by the researchers in response to that. As IEC members, the COVID research in the beginning of, by April, we were set to start research because it was as much a clinical institute as it was a public health institute. These were very unique because the rationale for an ethics committee's existence is the need to protect human participants in research. And the IEC is the voice of those who are not heard in the decision-making process, that is, to speak for the rights of the research participants. One should also remember that the challenges that we faced were not uniform across time and space. What happened in April and May was a lockdown, the kinds of fears that came out of livelihood and other issues By May, June, it was the continuing lockdown. And June, it was like the slow-faced opening up. July, then September, October, the situation at the ground kept changing rapidly. And so the kind of challenges we experienced were also not uniform. It also differed as to whether you were a clinician, a lab-based researcher, or a social scientist or public health researcher engaged with community-based work. For the first time, the pandemic brought home of how the need of researchers wanting to engage with the pandemic meant that IECs need to engage with the protection of researchers, along with the protection of human subjects of research. The engagement of the IECs by asking questions of researchers as what protections they were going to take themselves to ensure that they don't transmit or get affected meant that both agencies that supported them financially and institutions that facilitated the research had to engage with this topic. The IEC, in addition, also became a bit more flexible in terms of determining other means of consent from the very, very rigid, informed, written informed consent or witnessed informed consent that was the norm up to the pre-pandemic situation. IEC also had to put in place processes that enable quick turnover times, and this we did by developing SOPs, providing advanced timelines for research, and all the IEC members gave a lot of their time to enable at least COVID research to be reviewed in 72 hours in those days, early days. It has not been very easy to get IEC members to meet on various platforms because regulatorily, it's a very diverse group of people. Not all of them are, necessarily electronic savvy, though many have become by virtue of necessity. And the selection, the reason why a person is in an ethics committee is because they bring very unique skills to the table to protect human subjects. And definitely electronic media savviness is not one criteria. This means we have to tolerate variation in skills, variation in equipment, because the kind of computers they had, the competing demands for time, especially if they were busy clinicians, or if they were women with sick people at home, or there were other forms of vulnerabilities they had to deal with. In addition, there were the additional risks of familial risks for IEC members themselves, some of them who had family members become sick. And then there were the other healthcare workers who had clinical responsibilities. So we had to adjust and build over all this. It took a lot of work because you have to remember ethics committees in India are understaffed to start with. And this did not change during the pandemic. In fact, sometimes we had to shoulder greater workloads because the other more vulnerable staff in the secretariat could not reach, lack of transport, they had no laptops at home, they had no internet connectivity, they can't afford one. And the only one they had could have been used by their children because schools opened very early. Social science research, again, I'm going to talk as a researcher, had to start to look at alternative means of data collection. Telephone interviews were one. But the ethics committee said that given the peculiar vulnerabilities, we needed to, the poor human contact in the earlier phases of the pandemic meant that people were vulnerable to just human contact. And IRB, Ethics Committee warned us that we should not take advantage of such things. They said that informed consent has to be demonstrated. The volition, that is voluntary participation, had to be demonstrated through some form of response, either through text message or even a mobile phone call. In June, July, we were very afraid to implement this because of our work among migrant workers in Kerala, because even the cost borne through texting or making phone calls, we felt was too much to bear for them because they were only getting food. They were getting food and a place to stay. through the ages of the employers. So social science researchers, we were conscious that respondents should not feel obliged to answer. We used trusted intermediaries such as NGO activists, local self-government functionaries and others to be the point of first contact. If the potential participant was reassured, then the contact details were forwarded and we waited for missed calls and we returned the call rather as a demonstration of volition rather than expecting them to contact us. This call, even something as small as this called for being ethically aware constantly, on your toes, everyday ethics, to be sure that we did not become a part of the context that added to their difficulties. In the end, we still don't know whether we did right or wrong, but we at least tried. We found at that time that the health workers who were part of the group we had to interview were very carried huge burdens with minimal facilities, and our research work focused on their work with LSGIs. We chose not to contact them during those very difficult days of June, July, up to September, because they were burdened with a lot of local level responsibilities. We didn't want to burden them with research responses as well, even though we could have gathered more nuanced understanding of their fears, the stigma they faced at community levels, and the vulnerabilities that they experienced. It's a choice in these contexts to do research. It's a moral choice to do research or not to do research. And that is a burden we will continue to bear, but we choose not to engage with ASHAs and other grassroots level workers because at that point, it would have been an excess burden to carry. Thank you.
Great. Thanks, Dr. Ramanathan. Hi.
Rohan, would you introduce all the rest of the speakers in one go? And then I'll ask my question. So then we can. Thanks a lot, Mala. And back to you, Rohan, for the three introductions.
Great. Thank you. Up next, we have Dr. Karima Khalil, who. Just give me 1 second. Dr. Khalil is a medical doctor and a reproductive health researcher from Egypt. She's coordinated the Population Council's reproductive health program in Cairo for over a decade and has consulted with several other SRH organizations. She's a member of the American University in Beirut-based Choices and Challenges in Changing Childbirth regional research network. She's presently based in Delhi and is a consultant with the Oxford Policy Management Limited, where most recently she's led a study on the impact of COVID-19 on essential services and primary health facility providers. We also have with us Dr. Prabha Chandra, who's a professor and a previous head of psychiatry at NIMHANS in Bangalore, India. She served as a temporary advisor to the WHO and UNAID and is the president-elect of the International Association of Women's Mental Health. She's been a member as well as a chair of several IRBs and is particularly interested in the ethics of research in mental health and violence against women and children. She was the co-organizer of the second NBC in Bangalore in 2007. And during the pandemic, she's led 2 research projects involving sensitive data collection on the above topics. We also have with us Dr. Sanjida Arora. Sanjida is a public health researcher working at CEHAT, which is the Center for Equity into Health and Allied Themes. CEHAT undertakes research and action advocacy as well as services related to operationalizing health as a human right for marginalized sections of the community and acts as an interface between academia and progressive people's movements. Sanjida is also the member secretary of the ISC at the Anusandhan Trust. With that, I'd like to pass it on to Dr. Priya Nanda, who will ask these speakers specific questions that they will respond to as they speak. Over to Priya.
So thank you, Rohan, and welcome to the panel. Thank you, Mala, for setting the stage and really bringing up really important issues about the dynamic nature of research, COVID, how it affected IRB members, and how you had to make choices, how much to engage with health workers and system actors as respondents or participants in your research, because they had just a multitude of new responsibilities. And we'll get back to that issue in the discussion. I'm going to move to Karima now. Karima, you have done research with healthcare providers, precisely where Mala ended. And in doing so, you actually did interviews with system actors, both frontline workers and medical officers. Could you talk about what were the unique ethical challenges and complexities that came up for you as you were, one, developing the protocol and thinking about the ethics? And how did you kind of think about the practical adaptations to those challenges? In particular, what are some of the vulnerabilities that you were thinking about as you were developing and adapting to this research? So you can talk about both at the conceptual level and practical level, what were some of the considerations and adaptations? And I think in your case, you also have an interesting methodology where you had facility actors in an ethnography prior to COVID. So you have research which continued post-COVID with them. So you had some trust and rapport with players, and then you had other providers with whom you didn't have any contact except for mobile research. So over to you, Karima, for maybe the next 5 to 7 minutes.
Thank you very much, Priya, and thank you very much, Suneeta, and thank you to Cornet. And I'm very, very pleased to be here with you all today. It's an honor and a privilege to be on this panel. So thank you very much for including me. Yes, Priya, I was involved with 2 studies, as you correctly pointed out. One was an already ongoing facility ethnography study where teams had been in the field and had considerable in-depth, qualitative, face-to-face interaction with providers at facilities. And then another study, which we then initiated after COVID appeared, where we had no prior contact with providers at facilities. So obviously dealing with these, setting up, dealing with rapport issues and issues of trust and vulnerability were very different in these 2 settings, dealing with these 2 providers. So in the case of the providers where we already had established rapport, we went, of course, through IRB procedures in order to shift to a phone-based data collection methodology, given that lockdown had then happened. But one of the initial things, of course, that was very much on our mind was it really ethical for us to put an increased burden on these providers as they were running around trying to deal with lockdown and trying to deal with all the pressures that were happening, and migration and vulnerable groups who were coming for testing and isolation and setting up quarantine areas and going, many of their staff were going door to door to identify cases, etc. Was it really ethical of us to impose a burden on them and shift to a mobile platform and start calling them up and collecting information? But given that very little was known of what their needs were, we decided as a team that yes, it was justified and it was ethically acceptable to reach out to them, not to an extent that would impose a burden on them, but enough so that we would be able to hear their voices and give them a platform to voice the challenges that they were facing. With the other study, which directly targeted a different subset of providers in Bihar at about 95 facilities, we deliberately wanted to know particularly what the stresses were on the system, how well the essential services were able to cope, or to what extent they were affected by COVID, so that we could help inform the state system. And there we had no prior rapport, no prior trust, as I said. And so that was an obstacle that we tried to overcome by going through district level officers and having the district state officials inform them that we would be calling, etc., to put them at ease. But it was a challenge to establish rapport. And one way we did this was extensive also training of the interviewers, and made sure that they practiced active listening, that they took cues from the respondents, that they spoke and inquired about what the respondents wanted to speak about, and that they tried to allay their fears and acquire their trust as much as they could. But of course, establishing rapport over a digital platform is a challenge, and it's not as satisfactory, of course, as when you have a prior relationship with the respondents, as we did in the facility ethnography study, for example, with providers. it's a challenge. So I don't know if that answers your question, Priya, or if you'd like me to speak some more to that.
Were there any other unique challenges you wanted to note in this round? Otherwise, we can always come back.
Well, it's not that necessarily unique, but something, of course, that we, one of the studies that we worked on that was on a digital platform was, and I think Dr. Mala mentioned it, is that you miss out the most vulnerable groups. So in a community-based study a study of community women that was conducted by mobiles, one of the very big concerns that the most vulnerable women who didn't own telephones would not be reached. And then there's a question of sampling representativeness and the relevance of the findings. I think all of us who've adopted mobile phones as a platform for data collection have struggled with accessing numbers and the getting informed consent to call people, to reach out to people on their telephones. And in this provider study that we conducted, we sent an opt-out SMS prior to phoning, in addition to having district officers inform them that we would be telephoning them. And this was, so the opt-out SMS was sent to get their consent to telephone them. After that, once we reached them, then of course we did a verbal informed consent, which we also, in order to interview them, which we also recorded and sent a recording of that to them afterwards. The community study, the study of community women, recorded the consent that was taken by a partner organization that was facilitating the interviews, because it was a big women's community organization, and that informed consent recording was also recorded and kept a record of. I don't think that any of the challenges were particularly unique, but they were all new for us as a first time, doing research on mobile platforms. And so, of course, the length of informed consent statements, I think, was a challenge for many of us, and the language which is used typically in informed consent statements. And when you're not face to face with someone and you can't put things, in a different way and explain it once and twice and 3 times, it's challenging, because also you want to keep the phone call as short as possible so as not to make a time burden on people on the telephone.
Thanks, Karima. I think there's some important points that you raised, which have come up in our CONET dialogues earlier, is how the of necessity mobile interviews have to be short, but a large proportion of them have to be spent in building rapport and confirming consent. And that really affects the quality of the data. So I think all the work that we've done around ethics is leaning towards spending that time, because the reassurance and the confirmation of consent and understanding of the context where the person is really important. And you talked about something which is really important, which we'll carry on in the discussion around active listening. I know that this is something that you trained your investigators on, and you really picked that up in your interviews. So those are, I think, really important points for discussion. Did you want to add anything?
If I could.
Yeah. Yes, please.
Yeah, could I mention there were unexpected things that came from our different studies, which we didn't necessarily expect. I mean, we were very worried of impinging on people's privacy. It's always sensitive to interview people by telephone when they're in a home situation or when they're in a facility situation, particularly in a home situation. If we're asking about home stresses or gender-based violence, then women might not have enough privacy to respond. And similarly, interviewing providers in a facility, they might not also feel free to talk about challenges they're facing. But we were pleasantly surprised that in both of those settings, we felt very much that the telephone did offer women privacy to talk about the very difficult situations they were in. And similarly, a phone platform gave providers, we felt, a platform and an opportunity to voice their challenges in a way that they might not have been able to in a public facility situation.
Great. Thanks a lot, Karima. So we're now going to move to Dr. Prabha. And I think, you are going to bring to us perspectives of both conducting COVID research, of course, your perspectives from pre-COVID research, but conducting research and also being part of IRB committees during this time. And specifically talking about what were the guidelines that were available and were they sufficient as you were thinking about adaptations and the complexities of ethics of research. So if you can discuss what was available and what kind of adaptations you had to seek. And also because you were working with a vulnerable group, looking at mental health issues, so just the cognitive challenges of the community that you were addressing. Over to you, Dr. Prabha.
Thanks, Priya, and it's wonderful to be back at an NBC conference. So I think, these are very important questions, and Mala and Karima have raised many of these issues. So let me start with, being part of an IRB which looks at purely behavioral research. I think some of the challenges were very common to what has been mentioned earlier. A few things were that, we all had to do research pause. So the researchers had to come to the ethics committee and say, we can't continue this research because we've been asked by our funders to do a research pause. And so what does that really entail? What does it mean to say longitudinal research? Does it bring down the quality of the science of research in those situations? We had the ICMR acting quite fast actually, and giving us guidelines, and regardless of the possible sort of limitations of a guideline which came on very early in the pandemic, and maybe people who made those guidelines did not really know how it's all going to pan out, it did provide some sort of structure. And like many of the others have mentioned, I think one of the challenges was how do you take consent over the phone, and particularly with low literacy populations, with people with mental illness, and like you mentioned, like the cognitively challenged. So even for the best of us to provide consent over the phone or to take consent over the phone is quite challenging. And for people with mental health problems who find it quite hard sometimes to process so much of information, when they were face to face, we would show them visual thank yous and, little pamphlets and cards and, demonstrate things, while on the phone, there's only so much that you can do. So I think that was another huge issue. And I don't think we still have the answers for it, because a lot of our respondents did not have access to laptops or something that we could use, which was more friendly to visual kind of cues. So I think that is a challenge, and that's something that we need to consider, particularly when we're looking at justice issues. So if you want a good representation of everybody, then you ought to be taking people who are older, you ought to be taking people who have low literacy, you ought to be taking people with mental health problems. There's no point in only doing research on a certain group of people who have the wherewithal to sort of respond to these kind of consent forms. So I think that was one huge issue, and the IRB tried very hard to do something, but I think the guidelines also don't really, never provide for people with intellectual problems in any case, with cognitive challenges in any case. So I think that was a big problem. The other thing was, of course, about the length of the surveys, and like Karima mentioned, it's so easy to say, you should have only 30 minutes of question time. What would happen actually was consent would take a certain amount of time because you have to repeat the consent several times over the phone. And then, for example, I'm the PI of a longitudinal research where we work with mothers and babies and kids. And we had said that we'd record only the consent, as well as a slightly sort of free speech about how are you coping with COVID and these days and things like that. And what we would find is that in the free speech, they would say, it's all right, we're managing. But when we actually started asking the questions, they would start talking about so many other things, which did not get captured in the recorded version. So our RAs would come back to us and say, look, one, it's not finishing in half an hour because the women want to talk about what's going on. And second, the questionnaires are not tapping everything that the woman is saying. And we really want to capture that as well. And I think this is something that we might want to talk about a little bit more, that, how do you capture things beyond the realm of what a questionnaire can tap? particularly in these difficult times. So that was the second thing. Another very unique challenge, and I don't know how the others handled it, but our IRB struggled with it a bit, and the administration struggled, that reimbursement for time. So many of our research projects were, funded by other organizations, international agencies, and we normally gave, some kind of reimbursement for time spent, for wages lost, etc. And that used to be face-to-face. So we would give them so much money and take a receipt and everything. And now how do you do that transfer? The administration, for example, the institutional administration was not willing to use a UPI as a method of transfer. So then how do you do the transfer without being face-to-face? And then is it ethical then to have that possibility of, giving somebody a reimbursement for time in these difficult times, yet not having a mechanism for it? So I think these were some of the challenges that we faced as an IRB, and educating oneself about the ethics of survey methodology. Till now, surveys were considered to be sort of low risk, methods of data collection in mental health research or in behavioral research, where more investigative or more detailed questioning or qualitative interviews were more anxiety provoking. So we needed to educate ourselves on the ethics of survey research, and how do you direct them to agencies. If somebody says, I'm feeling suicidal, then what is our standard response? When all organizations, hospitals, clinics are shut, what is the kind of information you give them as an SOP? Where do they go to? Or if a woman says she's facing violence, what is the kind of information you give her to, where does she seek help? So I think these were the challenges. We try to work around it. Fortunately, NIMHANS had a Government of India helpline, a psychosocial helpline. So we were sort of directing them all towards that, and said that if you feel like this, call this number, and this is a toll-free number. So that was a big advantage that we had. It was a national toll-free helpline, and we directed many of our people there. But I think these are the kind of challenges that not all IRBs would have thought of when we're doing behavioral and mental health research and research with vulnerable populations. So I would stop here and bring up more later, maybe.
Prabha, I just have a very quick question. When you were giving these numbers, do you know if any of your respondents actually sought counseling from any of the hotlines that you served, passed on information for?
Yeah, so fortunately for us, we had, as I said, we had the NIMHANS hotline,
yes,
helpline. So I think because of that, we were able to sort of tell them that we will check with the person who's taken the call, so we always did a follow-up. So any respondent who was given the helpline or any other organization would always get it. And we had assigned one person just for that, to do a follow-up call and check whether the person had called, what kind of help they got, how satisfied they were. Not all the time it was satisfactory. And I think that's another issue that we need to really focus on, that when there are things like lockdowns and pandemics and limited access, physical access, the level of satisfaction with these kind of helplines. And sometimes women call back and said, nobody picked up the helpline, or it was in a language that I didn't understand or didn't want, or it was not very helpful. So we kept following up and trying to understand. I think that itself is something that you need to write about what you do, when you, because from our point of view, we send them somewhere and think our job is done, but it's really not done, isn't it?
Absolutely. I mean, this is something even within CoreNet, we had a lot of discussion, because it's not about ticking the box that, yes, we've given a number, because what is the quality and effectiveness of that helpline? As you rightly have said, it is something that came up a lot during our dialogues that Suneeta had discussed, which I'd like to get back to later. Thank you. We will go deeper into this conversation, because we're going to talk a little bit about research with women who experience violence. Sanjida, I'm going to actually, you can just like seamlessly start building on this conversation where Dr. Prabha has left off. I mean, I think the questions to you are very similar. around what are some of the issues that social researchers have faced during COVID. And you were particularly associated with the BMC, Bombay Municipal Corporation study on violence against women. If you can talk a little bit on the, the ethical imperatives of concerns around women's safety, and yet balancing the need to collect this data, which is something that even Karima discussed. So over to you, Sanjida, and I know we have your colleague also in the participants, and Sangeeta, who I might invite later into the conversation. Over to you, Sangeeta.
Okay, thank you, Priya. So, first of all, I would just like to highlight that why it is important to do research on the violence against women during the pandemic. So we all know that violence against women is a public health concern, and there is enough evidence in the public domain that the reporting of the domestic violence has increased during the pandemic. And supporting women during such circumstances, we actually need to build an understanding that what are the forms and the dynamics of the violence that women experience, what were the services which were accessible, and what were the interventions done by the various civil society organizations which were effective. There should be enough data on these aspects so that we prepare ourselves better for the future. But so if we look at the research on violence against women, there are always safety issues of the women. There are several ethical considerations, and we need robust training of the researchers to identify the signs of the distress among the women, and also to establish the referral mechanisms for the various support services and adverse events. All these considerations are magnified in the context of a public health emergency like COVID. And I would like to say that before embarking on any research on violence against women, we should fundamentally address two basic questions. Is it possible to accurately collect data on VAW without compromising the safety of the women as well as the researcher? And secondly, whether the data collected will be actionable. I think if it is not actionable, then there is no point in doing the research considering the crisis in which we are. And considering the lockdown and the other restrictions, it is difficult to collect data safely and reliably through the remote approaches, because the women are there in the house with the abuser, and we don't know whether they will be underreporting, non-disclosure, and most importantly, there will be participant bias, because we will only be able to reach to the women who have the phones. The more vulnerable will be left out. So I think the data coming out of this kind of the research is not going to help us to build the services or to do any action. And if there will be underreporting of the violence, it will further undermine the issue, right? I strongly feel that having no data on the issue of violence against women is better than having the inadequate or the underreported data, because it will seriously undermine the issue. And having the government to do something or doing the advocacy on this issue will be difficult. So there are various challenges of researching violence against women, and one of them is the safety of the women. And the other thing is we don't know whether we are talking to the right person or not over the phone. And the WHO guidelines and the UN Women Guidelines that recently released has said that we can use a methodology of the graduated informed consent, where you give little information to the person to whom you are speaking first, non-specific information about the survey, and then on the further contact you can actually give the specific information when you are sure that you are talking to the right person. And the confidentiality issues are also that we don't know whether the woman is alone in the home or whether someone is overhearing her conversation. And the other important thing is that when you have face-to-face in-person interviews, that researchers can pick up the signs of the distress, because when we talk about the violence, it is actually the quite emotional, traumatizing, and the women are actually reliving the experience. So that point is completely missing when there are remote approaches of doing research on violence against women. And the other thing is that there are a lot of apprehensions and fear among the respondents that why the researcher has called them, from where they got their information. All these things are there, although there are strategies like having multiple contacts with the respondent before actually starting the interview and having a script ready, or maybe the rigorous piloting of the tool can also be an option to see that what are the questions with which the respondents can be uncomfortable, or which the ones which are not clear. But I'm not sure that what are the relevance of these strategies as far as the research on violence against women is concerned. The other thing is that the WHO guidelines have clearly said that not to include any direct questions when you collect data remotely on violence against women. And there is not enough evidence on asking the violence in the form of the vignettes or a hypothetical situations, or maybe the proxy measures like the feeling of the fear or the safety issues. There is not enough evidence in the low middle income countries that whether this kind of methodology is effective. So I would like to say that what could be the way forward. So in CEHAT, we are involved in establishing health systems response in the Bombay Municipal Corporation Hospital, and also to provide the crisis intervention services to the women. And the one of the important aspect of the provision of the crisis intervention services is the documentation of the information shared by the women. This documentation can be in the form of the counseling intake forms, or the medical reports, or the legal papers of the women. And when the women comes to us, then the counselor asks the women about a safe number and the address where we can contact the women, and what are the timings when we can contact the women. So I just want to highlight that considering the situation we are in, can we use the service based data to generate the evidence, to inform the policy? And of course we have to follow certain ethical considerations, like the analysis of such data should be at the aggregate level, and it should be anonymized. And but it can usefully inform the purpose which we are looking at. So there are lots of civil society organizations who have done a lot of interventions during the COVID, like for example helpline for the patient's rights. So can we use that data to inform that what were the violations of the patient rights during the COVID? And I remember when so in CEHAT, we do a lot of research by using our service-based data. And I remember when we proposed this to our ethics committee, there were two questions that they asked. That one is that the woman has not shared her information with you for the purpose of the research. Then how can you do that? I think it's unethical at our part as a service-based organization if we don't bring that data in the public domain for any advocacy. With complete check-ins like aggregate analysis and the anonymized analysis. And then the committee asked that is it possible that before the counseling you take a consent for the women from the women that this data can be used for the research. But I think given the situation when a woman comes to a counselor for the help, for her the consent has no meaning. She will not be able to say no, right? Because she needs the services from the counselor. What is the meaning of having the consent at that point? And it will also jeopardize the counseling process, and can break the trust between the counselor and the client. And the other thing is it possible to take a retrospective consent from the women? We can take retrospective consent if the information that we are looking at is not there in our case records. But if we already have that information, then what is the point in taking the retrospective consent? Yeah, so I will end here.
Really, really important point, Sanjida, and thank you for bringing this unique perspective and walking us through the WHO guidelines, which very clearly lay out a lot of caution to do research at this time on digital, through phones. I think you brought up something really important, which I want other panelists to address before I open it up. The issue of using other kind of proxy documentations. I mean, not only using proxy questions in the survey, but you use that there's a lot of secondary information and data available, their case records. You talked about legal sheets, you talked about medical reports, you talked about civil society organizations that were really looking at violation of patient rights. Oh, and you talked about the ethics of underutilizing this when all this data is available. What is our role as researchers to kind of synthesize and collate insights from such data? So I'm going to like open it up to our panel first. Mala, Dr. Prabha, if you, either of you want to talk about this. So I'll start with Dr. Prabha. I think Mala, you might also want to add a few thoughts on this. So Dr. Prabha.
Absolutely. I think, using a lot of sort of secondary data would be extremely useful. So one of the things that happened was that the psychosocial helpline, which was started by NIMHANS. So for example, nobody had thought of how you can use this data to actually inform services, even when it was set up. And so one of the things that when we started doing our research and said, are our women or our children actually calling up this hotline? The people who are running the helpline realized that they had not taken ethics consent for analyzing the data of the kind of calls that were coming in. And they actually had recorded reams and reams of data, but did not have the wherewithal to sift through it or look through it. And this is extremely valuable data. So now what do? You haven't taken consent when people called you up that you might be using this data for a research study, or you might be publishing it. But yet it is such valuable data to not only to provide services, but to also inform helplines about what kind of traffic they are getting. So we didn't even have the themes of what was being asked. So I think it was such a waste of extremely valuable data. It was only much later that the group realized that you can't call this secondary data really, because it was data that people were giving. It was woes and their concerns there. It was live data. So you can't really use that. So, but then it is such a waste. So I think these are things which ethics committees may need to sort of think through in a situation like a pandemic, which is for the first time. What kind of data can be used with caveats, with enough, protection, so that services can be better informed. So this is one example of extremely valuable data, which was lost completely, and we couldn't use it. So
Mala?
That's from my side.
Mala, would you like to add anything to this?
Absolutely, because I agree with the co-panelists that it is a phenomenal lot of vital understandings. And there is, Prabha, in health systems, in medical records, even blood samples, discarded blood samples, leftover blood samples, we have a mechanism of anonymizing it when we can't reconsent and reusing them for other purposes. And medical records are constantly used. So if you could treat this as records and find ways and means with all the caveats, because, when you're looking at people of this kind, we don't know that there is any added benefit in recontacting them for consent. That itself could add to heightened risk. It is there that I think as ethics committees, we have to, contextualize alternative solutions that have emerged in different contexts to see parallels. And, surveillance data is constantly used for public health relevant action. Secondary data is...
I think one of the things, Mala, is that maybe when we are seeking consent at the first place, maybe we should be thinking of consent for a broad range of use of data and not in a limited way. And perhaps that's where the first time when you're seeking consent, you alert the person that this is all the ways this data could be used and assure for, privacy and anonymity and confidentiality, but maybe lay out the possibilities of data use.
you know, in these contexts, one could have an opt-out option for use rather than, you know, for use for other purposes.
Yeah.
Which we routinely do in medical contexts.
Yeah. What happened, I think, Mala, the thing is that, you know, when the pandemic came in and this helpline I mean, you should have seen the number of calls we got, like in thousands. Now, at that moment, the focus was on helping the person who calls you. You know, people didn't have a research hat on at all. And so things like consent was not discussed. Let me tell you one simple example. So as somebody who works with women, we realized that, you know, very early on that women were calling quite a lot. So the ministry then decided that they need to have 4 numbers, 1, 2, 3, and 4. And so 2 was for women, 3 is for children, and 4 was for the elderly, and 1 was for like a general thing. And when women called, they would talk about, you know, my husband is migrating, or where can I get a test done, or I'm scared I've got COVID and all. Now, this was a great opportunity to ask about violence. But it was not there in people's mindsets. You know, they didn't think about it much. And when I analyzed so I asked people, they had at least themes written down. And I said, how many, and if anybody reported violence, it would have been escalated to a senior person. So I said, how many were escalated? I mean, at least we got to know that much. And out of thousands, maybe just 20 were escalated, which is completely impossible because a lot of women who called might have had problems, but then we did not have the question in our mind and we did not ask. We started asking later, but I think we lost a lot of data in the lockdown and the initial phases when it could have been used. So I think it's also about learning from experience, but trying to document some of these things. And as opportunities lost, even if it is, even if we didn't do it, to think that something like this can happen again, and what research priorities and what research questions we can ask out of routine issues, which even Sanjida was talking about.
So, you know, I want to say on the chat, in the Q&A, I think Dr. Nandini Kumar is also talking about anonymization. One of the questions I would say that I would love to end this panel with is really what are the ways in which different IRB groups are networked in the country, especially during COVID? Because these, as you said, much of these learnings were real time. And perhaps one of the ways forward is to document these learnings into some kind of a guideline between all of you, because I think that's really important. If there's time, I will hope that we can open it up to the audience, and maybe you know, Dr. Nandini could speak from the floor. Before that, if Karima, did you want to add anything to this discussion? Otherwise, I was going to open it to a couple of our CONET members who wanted to add a few perspectives.
No, please go ahead. I'll jump in if
okay, great. So Sanjida, you can remain on video so that I know whether you want to talk, and you can just wave. So we, yes, I think Dr. Sangeeta Rege is here. Would you like to add any perspective on issues of violence, research, ethical concerns around research with violence against women? I think Sangeeta already laid out a lot of the context. If you wanted to add something, please go ahead. This may be the moment to come in. Okay, nothing to add. Okay, then I think we have Rupika, who's, Rupika, would you just come on?
Yeah, hi Priya, hi everyone, thanks.
Do you want to come on video? So just introduce yourself. You're a member of CONET, and we had invited you because as CONET members, we've had many dialogues around the complexities of ethics in the research we were doing, and maybe you can talk for a couple of minutes on what have been the insights that you have learned.
Yeah, thanks so much. I was organizing the video and the mute with the organizers, and it was really lovely hearing to everyone. And I think I'm from ID Insight, and we have had a couple of experience of phone surveys, and I would specifically like to touch on this recent survey that we are now planning for rollout on the gender-based violence for women. And some of the quick lessons I want to share here are like, one, when we are designing about the measurement of indicators, but also the questions that we would be asking, there's this ethical dilemma of, whether we ask from the context perspective, as Dr. Mala was suggesting, but also like, that data is really relevant, like all the things that Sanjida has laid out. So one of the things that we were fortunate to do is, because it was part of an evaluation where our partner organization was already, providing support for the gender-based violence issues. So what we have access to is this data where the women can reach out, respond, and the trainings that were provided, attendance and report of violence. So we are planning to use that data. And while I understand the concerns about the lack of evidence on use of vignettes and norms-based questions, the idea is to triangulate this and see if it works. And we use the WHO decision tree actually to come to a decision of what sorts of questions. So the prevalence questions and indicators were dropped versus these third person and vignettes were still preserved, and see if that could be a proxy for triangulating this actual reporting, which it's not really admin data, it is primary data, and I agree with that. And then in the process of not really only covering the women's group as respondents, but also what are the other institutional touch points that they interact with, and collecting that sort of data. So that's a little bit on the measurement thing. The other thing I would just add is from an internal perspective, like I think because we work with enumerators, I think it is also the responsibility from an ethics perspective to train the enumerators also, both to handle these situations and know what to say, like more so than as compared to the in-person interviews. So like, understand the limitations, but also the sensitivities of what to do and what not to do. And apart from these standard hotline support numbers, what we were also fortunate enough is like, we are planning to give these institutional, so our partners institutional support phone numbers. So, that's something that's an individual's number by name or something. So we know that they can contact and, will be supported on. And then the other last thing that I would add is the consent form per se also needed more, additions. So while the standard, like if it was an in-person, it is standard, the language and everything, but there is more information, there is more probing, there is more reminder. So even before every sensitive section, we again kind of mentioned, you can always opt out if you want, or we can skip this, or can we continue talking to you and things like that. So those are some of the things. Yeah.
Oh, excellent. Thanks, Rupika, because what you brought up is really practical considerations. And I really like the point around designing your survey and, kind of revalidating and recontextualizing it within this context. We also have Vineet, literally for a couple of minutes, Vineet from Dalberg, whether you wanted to share similar perspectives as Rupika. And then I am going to open it up to the audience. We are tracking your questions. So we may just summarize some of your questions and bring it back to the panel. So over to you, Vineet.
Hi, everyone.
Short intervention.
Yes. I want to start by saying that this has been very sort of thought-provoking discussion, and wanted to share a couple of points and learnings from on the survey that we did, which was about 17,000 households in India with a specific focus to understand gendered impact of COVID-19. Some of the topics we covered were employment and livelihood, food and nutrition, access to essentials, among others. So telephonic survey grappled with many of the challenges that have been discussed today. We did some of the things sort of, I think that would be obvious to a lot of you, but for example, female respondents only spoke to female enumerators, like sensitive questions around GBV or perceptions were removed for ethical reasons. And our colleague from ID Insight mentioned about the decision tree. I think that decision tree was very helpful for us too. And one of the things that I was thinking was perhaps one should think of such visuals and decision trees, right, when it comes to past lessons from past research, right? The other thing that we deployed was that while we knew that our conversations were always sort of female to female, we specifically again asked for separate consent for questions around sort of sanitary napkins and contraceptives, and only proceeded, for example, if they were comfortable with those sections. And then the other point, very similar to what you guys have already shared about, is around the part around sharing hotline, helpline numbers. One thing that worked really well was that enumerators actually waited while women were sort of asked to actually note these down. And many women, in fact, asked those numbers to be repeated, texted back, for example, on their personal numbers. So I think that we found very useful. But one of the things that we didn't do as part of the study was to see how many of them are actually calling back and so on. So that's a lesson that I take away from the conversation today. And then one last thing that I wanted to leave the group with is that there is always that sort of balance between consent script as well as the information that you seek, right? We personally felt that while we spent a lot of time to simplify the consent script, not just in English, but also in all the local regional languages that we interviewed in, we felt that the script was still a bit robotic because the enumerator was trying to sort of rush through. And it was very rare that women actually asked any follow-up questions on that. The response was always a yes, right, most of the time. And if there is a version of a decision tree, for example, an equivalent of that, that perhaps emerges from some of the work that you guys have done, would love to actually get insights on that or any lessons or best practices on that. So I'll stop here and pass it back to you, Priya.
Thank you. So we have now about 15 minutes for an interaction. We are officially opening it up. So I hope to see more traffic. But in the meantime, I'll probably take a couple of questions that I can see. There's a question from Nitish on non-COVID research. If the IRB you're affiliated with introduce new COVID-19 procedures and processes, what are they? And how did they communicate this to the researchers? So I think this, I'd rather open this up, Mala and Prabha probably, to like, how was the IRB learning and communicating back to researchers? Like, is there a process, active process of doing that? Or is it more reactive? Because from what Mala told me, the IRB itself was internally coping with capacity challenges, and a lot of adaptations and learning were happening real time. So when did you start kind of consolidating this, and if there was any ways in this was being communicated externally?
You know, we were coping and grappling with complications. I think we still will be, and it will continue. But we soon realized that chronic disease attendance, care seeking, the researchers began to recognize that there was a shortfall in the patients who really needed care and who were not seeking care because they had to come to hospital and they couldn't and so forth. So they needed to deal with that, and they came back with, we need to find out, follow up through telephone, etc., for routine patient care, which then had to document experiences of COVID and so forth. And then they themselves came up with the need to look at the impact of COVID on follow-up of routine medical care. So then we had to come up with ways and means of reviewing. First, the overlap was COVID and other conditions, chronic conditions or infectious conditions. Then it was the regulatory studies which had routine requirements, which we needed to deal with, for which, the committee was simply not equipped. I mean, we were a government institution, there was Zoom and the government banned Zoom. It's silly, it may sound silly, but it was things like this. And then, suddenly there was so much emphasis on ensuring that ethics committees physically met. Now we had to find ways and means to meet online when not everyone was equipped to do that. So it's not a mere learning curve of electronics. It's or software, or learning how to use Cisco WebEx or something. It's a matter of having appropriate computers which update. Connectivity became an issue when everyone started school. If you have one laptop at home and the kid has to attend classes, how is that going to be available even for an IRB member? And most IRB, things like this, it's
So Mala, I mean, I think what you're bringing up, that there were immense practical challenges, and let's not undermine that, because I think the volume of COVID research just went manifold. It just went up humongously, and the ethical challenges also were a huge surprise and shock. and people had to cope with all of that real time. And I think those are practical issues. Prabha, do you want to add anything to this? In the meantime, I would ask the audience that, now after this, we'll open it up, and I think the provisions are there for you to unmute yourself and ask a question. So, Prabha, would you like to add?
Priya, for your specific questions about how the IRBs were they iterative in their responses? And I think it's been a really good experience because, for example, we finished talking to 600 odd pregnant mothers in antenatal clinics face to face because they were coming, and these are from public hospitals. What happened was that it's somebody saying no audio. Am I audible? I am. Okay. All right. And so, how do you prevent the woman from staying on for a longer time just because you're doing a research study where actually you want women to leave hospital as soon as possible? So how to strike that balance? We are doing a saliva collection with young children, and saliva is very, very, full of COVID-19. So how do we do that? So the IRB suggested, can you train the mother to collect the saliva rather than the researcher collecting the saliva to minimize risk? There is an issue about getting MRIs done for research studies in people with neuropsychiatric illness. And is an RT-PCR, a rapid antigen, is it enough as a safety measure? So I think the IRBs are really learning and training themselves and things that they probably are not equipped to, but they've been very iterative. And I really think that many IRBs are actually asking very intelligent questions and also providing some very useful solutions.
Great. Are there any other reflections, Sanjida or Karima, you want to add? And then to this discussion, otherwise I am now inviting the audience to use the raise hand functions if they want to come in with their specific questions. Sanjida, Karima, anything? Okay. So I don't see people, I don't see any specific questions. On the previous, there was a lot of chat I saw during the time that we were talking about anonymization of data. I think, Dr. Nandini Kumar, I think you are in the audience. Do you want to come in at this stage, maybe, and add any reflections?
Hello.
Hi, please go ahead.
I'm Dr. Geraldine.
Oh, Dr. Geraldine. Okay, please go ahead.
I was actually listening to a tele-arogya series from AIIMS, Delhi. And I was seriously concerned that the obstetricians were actually promoting abortion and contraception as part of the care for COVID. And again, we had another, oration by Dr. Swaminathan of WHO. And again, one of the, interventions or the essential services to be given to women was this whole contraceptive services that should be made available for women. But I feel this COVID has brought, to our attention the destruction and, how a virus has really disturbed marriages and families and the care of our people. It has raised such serious moral and ethical questions in caring for those who are vulnerable. And I feel we really need to rethink, how we care for people and what are the measures we, reach out to families and societies. The old mindset of population eugenic, thinking, I think should be changed. And also I asked Dr. Prabha Chandra, what is the mental health status of a woman who's pregnant and, what would be the care she would need, especially that would be the focus to help her through the pregnancy and postnatally. Thank you.
Yeah, sorry, before Dr. Prabha responds, I think I think that resumption of essential services, which include contraception and all SRHR services, was an ethical issue when women needed these services. So I think I really commend our health system and health workers who probably have worked very, very hard to balance both COVID care and COVID work, as well as working on resumption of essential health services. For us, the biggest ethical predicament that came up during COVID was that women were unable to reach health centers or unable to get access to outreach workers for essential sexual reproductive health services. So I think that's absolutely non-negotiable that these services had to be resumed. And we really see remarkable results in the states that we work in, that within a few months, things started to work. And it's at the cost, a huge amount of cost to health workers. I mean, and everybody's talking about that. Dr. Prabha, did you want to answer anything around mental health issues?
I've actually answered it on chat already. So,
yeah. Okay. Okay, you answered.
I think Dr. Nandini Kumar is there, I think.
Yeah, I had invited her and I don't know whether she'd like to come in at this stage.
I can see her.
Actually, thank you very much for the opportunity. It was wonderful listening to all the presenters. In fact, I would like to hear it once again for everything to seep in, because it was so much of information suddenly coming onto you. My point about anonymization is that option, I have already answered that. That option is still open if the ethics committee, because I have seen many ethics committees insisting on written consent, and they don't understand the difficulties of COVID situation. I'm actually chair of DSMB for Ayush proposals passed by the Ministry of Ayush. And I can see there people insisting on the written consent. And I asked them, are you taking written consent? Yeah, we have no difficulty at all. I was surprised actually to hear that. But then they told me the mechanisms and that was possible. But then I said, there is a provision in the guidelines itself. Even before COVID guidelines came in, there was a provision that in certain circumstances, you can exempt that. You don't have to take consent. But this has to be documented and also approved by the ethics committee, which will decide on a case-to-case basis on this issue. Somebody has actually put in a question that for ongoing studies in between, is it possible not to take consent in between? That is possible, provided the ethics committee has read the guidelines and feels confident enough that in their judgment, they can actually give the exemption. So it depends, suppose you are actually going to see the mild cases or asymptomatic cases, their consent may be possible. But in severe cases, what do you do? Their LAR also will not be there because anybody would be prohibited to enter the premises. So what do you do then? So at that time, when it is impractical to do research, the provision is already there in the guidelines that you can do away with consent.
Great, thank you, Dr. Nandini.
Dr. Nandini, it's very, very important to hear you say this, because I can tell you that ethics committees still want signed witnessed consents, even now. It's like a kind of, shall I say, Bible or something that they hold on to and are quite unwilling to give up.
Another point that had come up was that one of the researchers said that because this insistence on written consent was there, so she was using the electronic means for that. And initially it was written consent, and she found that even literate people refused to sign. They were so suspicious and they didn't want to sign at all. So those who had signed when she was giving them the copy, they refused to take it. This is the status with the literate people. Then you can imagine what would be the status with illiterate people.
I think we're getting signals that we have to wrap up.
Yeah, we have to close. So I'm going to invite Suneeta to just do literally a 2-minute wrap up, and I think we'll hand over to Dr. AMCHSS after that. I want to, before handing it over to Suneeta, thank all of you, great audience, and just say that from our perspective, CoreNet, what we will do is to kind of document this discussion in a manner which could be shared with everybody here. And definitely I see this kind of real emergent need to document what IRB committees themselves have learned during this time, and create probably more networks between them, at least informally, through sharing of these learnings. Over to you, Suneeta.
1 minute from Jasani to wrap up. So first, I think what we've really learned is that doing ethical research is a process of continuous learning and adaptation, especially in a dynamic crisis situation such as the one that we've encountered this year. And this is true for IRBs as much as it is for researchers. Second, we have to pay close attention to the risk and burden to benefit ratio, as well as who is left out. Third, it's important to pause and consider what are the new challenges and risks that we need to address in our research, and whether the research is really necessary at this point in time. Fourth, researchers must pay attention to justice issues. All population subgroups deserve to be counted. But the guidelines, as Prabha said, don't really help us figure this out. So we have to get more creative. Fifth, there are many questions related to issues that we've answered and sort of squared away in pre-COVID times that need to be revisited now. How do we capture experiences that go beyond the realm of what an IRB-approved questionnaire is documenting? Is reimbursement absolutely essential? Are we really conversant in survey methodologies, for example, and what the implications might be for people's mental status? Sixth, we've been challenged to find novel ways of doing research, and I think we've discussed quite a bit the use of anonymized medical records, counseling records, helpline records, etc. And seventh, we need to really innovate on the practical aspects of doing ethical research. For example, I think multiple references to the WHO decision tree suggest that we need to be producing more of these really usable, very pragmatic tools to ensure that our research is ethical. Thank you so much for this opportunity. This was such an inspiring and provocative discussion. Looking forward to getting together, maybe in 2 years, not 13 years from now.